Alright guys, welcome back. So continuing on psychiatry, last time we left off at our discussion of the various differences between the schizophrenia spectrum disorders. We looked at the concept of, positive, negative, and cognitive impairments, what it means to have positive symptoms where you are now gaining something you didn't have before, such as hallucinations. What it means to have negative symptoms where you lose something you did have before, such as losing emotions, right? So you have a blunted or flat affect. And cognitive impairment where you just can't speak correctly or you don't pay attention, something like that. All those symptoms come together to give you schizophrenia, which is further subdivided based off of a time span, right? So for schizophrenia, you need to have one or more months of active symptoms over the past 6 months, right? And the 6 month point is the cutoff point. Between 1 to 6 months, it would be schizophrenic form, where you have 2 or more symptoms, okay? And less than 1 month was a brief psychotic disorder, right? And the positive symptoms are usually the symptoms that truly point out someone having schizophrenia, right? Negative symptoms can be seen oftentimes even in things like depression, right? Not having emotions, having social withdrawal, right? You can have social withdrawal and depression. But positive symptoms more so are very specific to psychosis. And depending on what else you see, you can classify the patient to be schizophrenic. Because you don't really get hallucinations in basic mood disorders, depression. You don't get delusions. You don't get disorganized speech or bizarre behavior in depression. We further went on to see the difficult comparison of schizophrenia versus schizoaffective disorder. Remember, affect is emotion, right? To be affectionate, right? So affect. Schizoaffective disorder was different from schizophrenia, but very difficult to catch sometimes. But it's a pretty thin line depending on the question and the way it's been written. But basically, in schizoaffective disorder, what you're looking for is a patient who's had depression or some kind of very bad mood disorder throughout the entire clinical presentation, throughout the entire question scenario. But they've also had, though, moments where they were just doing very schizophrenic things, either hearing voices, seeing things that aren't actually there, delusions, stuff like that. Both things happening together. Whereas in pure schizophrenia, you don't really have depression symptoms. You don't really have something like lack of appetite, for example. Right? You're not supposed to see that in a patient with just schizophrenia. But lack of appetite and lack of wanting to do something you would used to enjoy before, those are things that are more so related to depression. And if you start seeing that plus positive negative symptoms, stuff like that, that's schizoaffective. We did a lot of practice questions in the last video, right, where we got to see some questions where the answer was schizophrenia, whereas other questions where the answer was schizoaffective, like this one here. Right, so this one's pretty cool because this AMBOSS question here had presentation of 4-month history of decreased appetite. It's a 23-year-old young woman. 4-month history of decreased appetite. She's just not eating much. She's not sleeping much. She's not able to focus at work. She feels empty inside. Right, so those are all pretty depressing. But then she also hears voices of being told she's worthless. And all of that started 7 months ago where she started hearing voices, right? She doesn't do drugs or anything like that, so those differentials are gone. And she abruptly stops talking, which is also schizophrenic. So she has these symptoms of both things, schizophrenic things as well as depressing things. And you can see how only 33% correctly chose schizoaffective. 43% of people failed to catch that this is schizoaffective and actually chose schizophrenia. Right, so be very careful. You got to see both things. In questions that are purely schizophrenic, like the one up here, you're not going to see a single thing about a mood disorder or depression, right? So this 28-year-old man found sitting outside drinking his own urine. Mother says he broke up with his girlfriend, quit his job, and started becoming increasingly socially isolated. That is a sentence that's there to really start making you think, oh shit, is he depressed? Is he having some kind of mood disorder, right? Socially isolated, breakup. But it's not that. He's socially isolated because of his schizophrenia. It's something that he wants to do because of his schizophrenia. She noticed that he no longer seems to care about activities that used to interest him, which also sounds like depression, right? In the past month, the patient has disconnected his phone and slept in the garden shed with his dog. See, that sleeping in the shed with his dog is a thing he's doing because he's schizophrenic, not because he's depressed. On exam, he's just not well kept at all. He later becomes angry, refuses to sit for the chair interview, right? A lot of things in this question. Oh, and then when asked where he lives, he answers in the holy buffet of diplomacy, blah, blah, blah. This question had many things that you could go ahead and think, oh, looks like he's depressed, you know? But he's not. This isn't a question about depression. His scenario of clinical presentation here and history does not include a scene where he was just depressed without major, schizophrenic activity. He is literally only schizophrenic. There was another answer choice. 21% of people fell for the answer choice of major depression with psychotic symptoms, which is something we're going to look at today. All right. So you got to be able to make those differentials. This guy just has schizophrenia, whereas the other guy we just looked at the bottom here, right? This woman, 23-year-old woman, only has schizoaffective disorder. And right up here we had a third question. 33-year-old man hospitalized by neighbors reports that he's been singing loud, right, playing the piano all night, claims that he's related to the president, which is bizarre, hears voices, which is schizophrenic. Patient says his mood is terrific and he's been putting all his time and energy into working on his masterpiece performance, which is pretty, sounds like a manic kind of thing, right? He has endless energy, right? Remember hypomania and mania, those are scenarios where you have so much energy and decreased need for sleep and food and stuff like that. He's presenting with that kind of stuff so far. The hospital, he makes sexual advances towards some nurses. He's had multiple psychiatric hospitalizations since age 22, typically presenting with similar symptoms. And the last time he was admitted, he was hospitalized for 3 weeks for hearing voices. Okay, but at that time, he was fearful, but he displayed no other mood symptoms. So you can see he's doing both things, right? He's doing the schizophrenic things. He's also doing these very manic things. Now it's not depression this time. This is a different mood disorder. It's bipolar. So again, here the answer was only 25% of people got it right, schizoaffective, right? Well, 33% chose either bipolar disorder with psychotic features, and 33% chose schizophrenia. You don't want to be part of that 66% of people that got this wrong. So you really got to solidify being able to make that difference and understand that difference between these few schizophrenic things. Schizophrenia, schizoaffective disorder, and then what we're going to start looking at now related to major depression, right? You see MDD with psychotic features, and then what was the other answer choice they had there? Bipolar disorder with psychotic features. So we're going to jump into all of that now, all right? So make sure that you can really truly see the critical difference between schizophrenia versus schizoaffective versus major depression with psychotic versus bipolar with psychotic symptoms, all right? So we finished up to schizotypal personality disorder last time, where schizotypal was a cluster A personality disorder that also falls on the schizophrenia spectrum, and we're going to look at all the personality disorders separately when we get there. Now we're up to here. So the book starts off with first explaining to you what is a mood disorder. Mood disorder is characterized by an abnormal range of moods or internal emotional states and loss of control over them, right? So internal emotional states and loss of control over them. Severity of moods causes distress and impairment in social and occupational functioning. It includes major depressive, bipolar, dysthymic, and cyclothymic disorders. Episodic superimposed psychotic features like delusions, hallucinations, and disorganized speech behavior may be present. Okay, so these are mood disorders, where you have episodic superimposed psychotic features. But we're going to see later on that the main thing here is that they're superimposed. So that basically means that you're not really going to see psychotic features without the depression, okay, in mood disorders. In pure mood disorders, any of those psychotic features have to be with the mood, okay? If you see just psychotic features without the mood disorder, that's different. So for a mood disorder, any psychotic features, if you want to pick your answer choice of maybe major depression, bipolar, dysthymic, or cyclothymic, if you want to pick one of those 4 answer choices, you have to make sure any psychotic features in the question stem occurred with the mood. So while the patient was depressed, he was hearing voices. That's superimposed. So this is just a table from USMLE where they were kind of breaking down these 4 answer choices. So episodic things are major depression and bipolar, whereas chronic things are the thymias, dysthymia and cyclothymia. Right? Major depression and dysthymia both have downs, very, very down mood, sad mood. So it's easy to remember because they have the letter D in their names. Whereas bipolar and cyclothymia, they have ups and downs, right? So bipolar has bi, which is 2, and cyclo is cycling between ups and downs. So very easy to remember that. So the first thing they talk about here now is a manic episode. This is a distinct period of abnormally and persistently elevated, expansive or irritable mood and abnormally and persistently high activity or energy lasting more than 1 week. Diagnosis requires hospitalization or marked functional impairment with 3 or more of the following dig fast features, right? So you can see some of these are really great to have and some of them not so much. So distractibility, not so good to have. Impulsivity and indiscretion, right? Seeking pleasure without regard to consequences. Being hedonistic, not so good. Grandiosity and inflated self-esteem, okay, not so good either. Flight of ideas, right? A bunch of racing thoughts could be good depending on what the ideas are focused on. Very goal-directed activity and psychomotor agitation. Right? So these guys are going to be working super hard to achieve what they want to achieve. They have a decreased need for sleep. These two are pretty good to have. And a lot of talkativeness or pressured speech. Okay, so dig fast. These are the few things that you are definitely going to see in people who are having a manic episode. This is actually a psychiatric emergency, right? USMLE goes on to explain that these people are prone to extremely dangerous behavior, and 50% are also psychotic. Must hospitalize, involuntary if necessary. Treat acute manic episodes with atypical antipsychotics, and you have to rule out any stimulant intoxication by doing a urinalysis and making sure if you can see they're just maybe doing some kind of drugs or something, and that's why they're acting the way they are. If their urinalysis comes back perfectly fine and it's not because they're doing any kind of drugs or anything, then they're having a manic episode and you have to hospitalize them because these people can end up hurting themselves or hurting someone else, and that would be really bad. Okay, I'm going to come back to this question after we do more. So the next page then explains hypomanic, right? So this is right after manic. Hypomanic is similar to a manic episode, except the mood disturbance is not severe enough to cause marked impairment in social and or occupational functioning, or to necessitate hospitalization. So these people don't have to be hospitalized. They don't have any psychotic features, and this usually lasts 4 or more consecutive days. So this actually looks sarcastically pretty cool, right? This is great. This may increase functioning, and you may have the manic characteristics like endless energy, extra confidence, no need to sleep, all without the psychosis, right? So this does actually look pretty cool. I mean, yeah, of course, you don't want to be hypomanic, but these people with the hypomanic and not manic symptoms are actually all right. Whatever they're doing is still going to be bothering people, and it's still going to look weird. Obviously, not something that you and I would do, but it's not going to be as bad as a manic episode where they have this crazy impulsivity and talkativeness, pressure of speech, any kind of psychosis. Not going to be there. All right, so now where manic and hypomanic come in clutch is being able to define bipolar as either bipolar 1 or bipolar 2. Something that a lot of students don't really tend to retain and memorize. Okay, so you gotta know it. You gotta know it by heart. You should be able to differentiate between the two and explain what the difference between the two is without having to Google it real quick or anything like that if someone asks you. So bipolar 1 is one or more manic episode plus or minus a hypomanic or depressive episode. Okay, and these things may be separated by any length or time. So in someone who is bipolar, you're going to have manic, hypomanic, or depressive, all 3 kinds of things mixed in some way. Okay, so you can have everything, or you could have someone who is just manic, right? Point is, bipolar 1 requires one thing. You have to be manic, right? This is a necessity. The plus or minus means that you don't necessarily need the hypomanic and depressive part, but if you're doing manic things, you are bipolar 1. Need to be hospitalized, right? So far, so good. Bipolar 2 does not have mania, right? No history of manic episodes. That is the essential thing. So if anyone ever asks you, hey, what's the difference between bipolar 1 and bipolar 2? Well, bipolar 1 is defined by the major issue of mania. If you're doing manic episodes, if you have manic episodes, as a bipolar 1 patient, you have to be hospitalized. because manic episodes require hospitalization. It's a psychiatric emergency. Bipolar 2 is a hypomanic and a depressive episode with no history of manic episodes. Okay, so bipolar 2 has two things. That's how I always talk about it, right? Bipolar 1 has one thing, a manic episode. Other things might be seen, but definitely has a manic episode. Bipolar 2 needs to have two things because this is an and sentence. You need to have hypomania and depression. Right? Patient's mood and functioning usually normalize between episodes. Use of antidepressant can actually destabilize their mood. They have a high suicide risk, and for treatment of these patients, you use mood stabilizers. Do not fall for using antidepressants. They're really going to try to convince you into picking an answer choice where you pick an antidepressant. In fact, the question might even say, what should you prescribe this patient to help them with their depression? To help them with their depression, you're going to give them mood stabilizers. Right? Once they're mood stabilizers and they're not doing those hypomanic things, they can start getting a little better in the depression aspect as well. Right, so really got to be careful with that because they love tricking you into picking some kind of antidepressant, an SSRI or anything like that, as an answer choice. And you can also use atypical antipsychotics here. Okay, so bipolar 1, manic, bipolar 2, hypomanic, and depressive. Right, and then extra notes I wrote here. So while bipolar 1 has higher highs and is much more unpredictable because it's very manic with the dig fast characteristics, hypomanic episodes, that's BD1. The depression in BD2 is more severe and frequent, and patients cycle more often between the two. BD1 may have depression, but BD2 always has it. Suicide risks are higher for BD2 patients as well. First line of treatment is lithium. Second line is valproate and carbamazepine. Lamotrigine is more effective at the depression than the mania. The atypical antipsychotic quetiapine works too. Right, so here they listed a couple of them: lamotrigine, carbamazepine. They didn't list any of the antipsychotics you would necessarily use. Quetiapine actually works very well for bipolar 2 patients, if nothing else is really helping them. A lot of patients can't really necessarily take lithium. For example, if you have a pregnant female, right, they can't take lithium, valproic acid. You also can't give lithium to patients who might have like nephrogenic DI, right? So you have to be careful what medication you pick as an answer choice. That's where the pharmacology kicks in. And when we did neurology, we discussed some of these medications like lamotrigine and valproate, and those medications are still being dragged on into psychiatry as well. So make sure you go back and review them. If you forgot what their side effects were, how they function, what their mechanism of action is, it takes some time to actually get that down. Now, the third thing that they discuss under bipolar disorder is cyclothymic disorder, right? The one that cycles between ups and downs, right? So cyclothymia. This is the chronic version of bipolar, basically. Right, so here you see milder form of bipolar disorder fluctuating between mild depressive and hypomanic symptoms. Okay, must last 2 or more years with symptoms present at least half of the time, with any remission lasting less than or equal to 2 months. Okay, so this thing is defined as a very long-term thing. Most questions you'll get about bipolar 1 or 2 will not cross the 2-year pattern, but as soon as they start telling you something's been happening in a patient for over 3 or 4 years, something like that, that would be cyclothymic disorder. You would just pick that if you see it as an answer choice and just move on. Okay, so that's something very important to remember that there. So we just looked at bipolar disorder being defined by hypomanic and manic episodes, which are all mood disorders, right? Everything here was a mood disorder, not a psychosis. There might be psychosis in them, in these patients, but any psychosis you would see would be with the mood disorder, never alone. You're never going to see psychotic episodes in these patients without a mood thing, like they're not depressed or they're not excessively happy or something like that. Next thing, this is also one of the extremely high yield topics: major depressive disorder, MDD. Episodes characterized by 5 or more of the 9 diagnostic symptoms lasting 2 or more weeks. Must include patient-reported depressed mood or anhedonia. Right, the 9 diagnostic symptoms are your SIG-ECAPS, all of these things, and it has to include the patient telling you, I haven't been so happy lately, or I don't really enjoy doing things I like to do. It has to be patient reported. Screen for history of manic or hypomanic episodes to rule out bipolar disorder. Especially screen for hypomanic episodes because you know you're going to see depression in bipolar 2, right? Remember, bipolar 2 has two things, hypomania and depression. Treatment is cognitive behavioral therapy and SSRIs, right? Depression, you use SSRIs, fluoxetines, sertraline, those guys. SNRIs, mirtazapine, bupropion can also be considered, okay? And these are other medications we're going to see when we get to the pharm section. Electroconvulsive therapy is used in treatment-resistant patients, and the patient has to basically opt in for it. You can't just go ahead and do it. The patient has to agree to it. So what are your diagnostic 9 symptoms? Depressed mood, hopefully something that your patient directly tells you. Sleep disturbance, usually patients who can't get enough sleep, they don't really feel sleepy. Loss of interest, which is defined as anhedonia. This is another thing that they can just come and tell you. I don't really enjoy doing what I used to do. Guilt or feelings of worthlessness. Again, this has to be something you have to watch out for. This is something they should be saying themselves. It shouldn't be that they're saying, I hear voices telling me that I'm worthless. Okay, that's more schizophrenic. Energy loss and fatigue, right? Which is, remember, this is opposite of what you would see in mania and hypomania, right? In manic and hypomanic patients, they have excessive energy. Right? So this is a very nice differential between the two. Concentration problems, appetite, weight changes, psychomotor retardation or agitation, and suicidal ideation. This is a scary one. This one is something you always directly ask, right? Remember, when you get patients with depression, these are not psychotic patients. So you can ask them, hey, so have you had any thoughts of suicide? And they might say yes or no. If they say yes, the next question is always, do you have any plan for how you would commit that suicide? Okay, very important to understand the suicidal ideation part. If they tell you, right, if a depressed patient who doesn't have any psychotic issues at all, if a depressed patient tells you that they do have suicidal ideation and they do have a plan for committing suicide, now you have to look into the fact of whether or not there are any guns that they can reach out to, either because someone else in the house is a gun owner or they have a gun, whether legally or illegally. And if they do say these things, that they're going to be suicidal and they have a plan for suicide, you have to go ahead and hospitalize them. You have to keep them in there. You can't let them go home because they can just go commit suicide. Man. So now, here in the beginning, they did tell you have to screen for history of manic or hypomanic episodes, right? So this is really important. I wrote here, you must rule out bipolar disorder by checking for any manic or hypomanic episodes. Monotherapy with antidepressants, remember, was actually a problem, right? If they have bipolar disorder and you make a mistake and you diagnose them with major depressive disorder, you're going to start treating them with antidepressants, and that's going to further worsen their bipolar disorder. Use of antidepressants can actually destabilize mood, leading to a bipolar 2 patient actually going ahead and immediately committing suicide, possibly by just overdosing on the antidepressants you gave them. So it's very important to rule out bipolar disorder. If you give an antidepressant to a bipolar patient, they're just going to go ahead and do really bad things and possibly even die. Depression generally presents with lack of sleep, fatigue, disinterest in food, or any other things they would find pleasure in. The outstanding features are suicidal ideation, guilt, and anhedonia. In the sleep graph, this one right here, right, with this REM sleep and the stages of 1, 2, 3, and 4, right, these are your stages of sleep that you normally see. In the sleep graph below, the green line represents normal sleep. Okay, so the normal sleep you can see follows the same thing in the beginning, but there's stage 4 sleep, right? You can see the green line goes all the way to stage 4, which is your really deep sleep, and then comes back up, goes back to stage 4 again, comes back up, comes back down to stage 3 this time, and then you eventually wake up because it's almost morning time now. The red line represents sleep in melancholic depression. Melancholic depression. The first red ridge has a prolonged REM sleep. This one right here. You see how long this REM sleep is? whereas the first REM sleep in a green one in a normal individual is not that long. Prolonged REM sleep, and the second ridge represents a nighttime awakening. Right? You can see that the second red one actually came way too far up. They're awake in the middle of the night. Right? They just can't sleep well, cannot sleep well. Awakening that is not seen with the green line. The red patient has no slow wave sleep at all. So there is barely any stage 3 or 4 sleep, while stage 2 sleep is getting prolonged. Okay, so you can see that the stage 4 one the red one, the schizophrenic, the depressed patient, the melancholic depressed patient does not have any stage 4 sleep, and they have a nighttime awakening. These are things that they can describe to you. A patient might come tell you, I keep waking up at night, I don't wake up fully rested. These are things that are very critical and tell you that the patient has depression. Now, under major depressive disorder, there are other answer choices that you're going to see too. And these other answer choices that you're going to see have specific things that make them different from just major depression. Okay, so what are the things that make these three different from just major depression, and what are the things that make major depression different from bipolar? Right, so we already saw the bipolar difference, right? In bipolar, you would have some things that don't really match with depression. In bipolar, you're going to have that hypomanic thing of having excessive energy. Way too much energy. Yeah, you're going to be awake at night, but you're going to be awake at night actually achieving some kind of goal, right? Something like that. Those are things that are going to be seen in patients who have bipolar disorder. I think, generally speaking, the general public has a very good understanding of major depression, right? What is just major depression? Anything outside of that concept of major depression is usually bipolar. Right? Now let's look at MDD with psychotic features and how you're supposed to understand that this is not bipolar too. So MDD accompanied by hallucinations or delusions. Psychotic features are typically mood congruent, where depressive themes of inadequacy, guilt, punishment, nihilism, disease, or death are going to pop up. Right? Mood congruent. Psychotic features occur only in the context of the major depressive episode versus schizoaffective, right? So what was the difference here? In schizoaffective patients, you're going to have episodes of schizophrenic things that have nothing to do with depression, and then you're going to have other episodes where it's not schizoaffective or any of that, it's just a mood disorder, okay? Those two things happen individually. Whereas in MDD with psychotic features, it's literally with, together. So that means every time this person has a mood disorder, they might also have psychotic symptoms together, right? So the two things occur. Psychotic features occur only in the context of major depression, right? That's MDD with psychotic features. This is literally just depression, though. There's no other mood disorder here, right? So in MDD with psychotic features, this patient is going to have very bad depression, which means he's going to fit all of this, but then every time they feel this depression, they're also going to have some kind of psychotic feature, like hearing voices or seeing things, something really schizophrenic there, right? And that is actually MDD with psychotic features. The same scenario becomes schizoaffective, and the two things happen individually. Sometimes the patient is very, very depressed. Sometimes the patient is hearing voices, even though they're not that depressed. Okay? And schizoaffective wasn't just depression. Schizoaffective also had other mood disorders. Maybe the patient is having a manic episode, right? And they're hearing voices and seeing things at different times. That's schizoaffective. Schizoaffective has to do with affect, and affect is about mood. Okay, so that's the major difference between the two. So if you have both answer choices, MDD with psychotic features and schizoaffective, the only way to pick is to first figure out if the two things occur together. If they happen at different times, it's going to be schizoaffective, right? You treat this with the same stuff, antidepressant, atypical antipsychotics. This is just a chronic version of that. So persistent depressive disorder, right? Dysthymia is a chronic version of MDD. This is often milder, with 2 or more depressive symptoms lasting 2 or more years, with no more than 2 months without any depressive symptoms. Right? So chronic. So you keep having MDD, that goes away for about a month, then comes right back for more than 2 years. Right? So now you are dysthymic. Last one is MDD with seasonal pattern, which used to be called seasonal affective disorder. Right? So you would remember this as SAD. MDD with seasonal pattern is 2 or more years of 2 or more major depressive episodes associated with some kind of season, usually winter, and absence of non-seasonal depressive episodes. So maybe during the summer, you're perfectly fine. Maybe during fall, you're perfectly fine. Atypical symptoms are what's going to make this very, very unique, right? Atypical symptoms are hypersomnia, hyperphagia, and lead-in paralysis. What are these 3 things? So these 3 things don't match with depression, right? In depression, you have appetite and weight changes that usually involve not eating much. Here, and you also have the ability of not sleeping well, right? Sleep disturbance that usually involves not sleeping enough. But MDD with seasonal pattern, these people are going to have depression only during a specific season, and in those seasons, their depression is going to have too much sleeping, too much eating, and lead-in paralysis where they get paralyzed if they ever go through any kind of actual strong emotional stimulus. Okay, they get a very weird, heavy paralysis. Very unique thing. You don't see these things in just MDD. You also don't see it with MDD psychotic features, and you don't see it in dysthymia either. Okay, so if they give you one of these 3 things, that's when you have to pick MDD with seasonal pattern. The last thing here, depression with atypical features. Okay, so what are some more, right here, the same thing, the same atypical symptoms. What does it mean to have depression with atypical features, and what makes this unique? The most important thing here is that treatment is a little different now. So this is characterized by mood reactivity, which is, again, something you do not see in just major depression. You don't see mood reactivity in bipolar either. What is mood reactivity? Predominantly depression, but patients have the ability to experience transient mood improvement in response to positive events. So someone who's very depressed, but maybe they get a promotion and now their mood gets really, really good. Okay. Hypersomnia, again, hyperphagia, lead-in paralysis, a heavy feeling in arms and legs, right, which is the same. This lead-in paralysis that I described earlier, where you can have the heavy feeling of paralysis leading from a very strong emotional stimulus. That's usually how you're going to get it in the question. Right? It's not. Oftentimes they might just tell it to you that the patient's arms and legs feel really heavy. Other times they'll tell you that after going through some kind of emotional moment, they feel a heaviness in their arms and legs. Long-standing interpersonal rejection sensitivity. Okay, so rejection sensitivity also falls under the same stuff of mood reactivity, right? Your mood changes based off of how you're treated or rewarded in life, I guess. Okay, most common subtype of depression. Treatment is again CBT and SSRIs, but you can also use MAO inhibitors now, right? MAO inhibitors are effective, but not first line because of their risk profile. Okay, so now that we've talked about these main differentials, let's take a look at some of the questions I have here. First one here, this is a bipolar 1 patient. So remember, bipolar 1 has one thing that you need to have, a manic episode. There might be some other things, but it's plus or minus. Bipolar 2 needs to have 2 things, hypomanic and depressive episode. So in this patient, 26-year-old, brought to the emergency department by police after assaulting customers in a restaurant. He explains that he meant no harm and was just trying to talk to people and touch them to heal their pain. So that looks pretty schizophrenic so far. The patient says he has been up all night for the past week devising a global strategy to end world hunger. Now that, right, so his main goal is to end world hunger, and he's been working very, very hard, staying up all night. That's very manic, right? That's literally the manic thing people do, or what people who are manic do. He hears a voice telling him that he is God's true son and will need to sacrifice his life. The patient has no psychiatric or medical history, drinks socially but does not use drugs, and physical exam is normal. On mental exam, he is disheveled and paces continuously. His mood is very irritable and his speech is loud, rapid, and hard to interrupt. What is his diagnosis? Okay, so a lot of people would fall for picking schizophrenia here, with him hearing voices and him, having this very psychotic thing he's doing. But this was just bipolar 1 with psychotic features. Okay? So how is this bipolar 1 with psychotic features? Well, this is a patient with severe manic symptoms, and his delusions only occur during a manic episode. Okay? That is what makes this bipolar 1 with psychotic features. Bipolar 2 would require hypomanic episodes with severe depression, And there's no depression in this question stem at all. So you can definitely make sure you don't need to pick bipolar 2 as an S choice. This is not schizoaffective, again, because you're not seeing a mood disorder that's occurring individually without the psychosis. The two things are happening together for the most part, right? And this is not anything depression related at all, so you don't pick MDD with psychotic features. You would just pick bipolar 1 with psychotic features, right? Because bipolar 1 is a manic episode, right? Plus or minus hypomanic or depressive episodes, right? And hypomanic has no psychotic features at all, right? But the manic stuff does have psychotic things, okay? Flight of ideas, impulsivity, grandiosity. These guys have many issues, and these patients have to be hospitalized. So he's completely just a bipolar 1 patient with psychotic features. Very important to be able to catch that. Schizoaffective and schizophrenia, these are also things. Remember, for you to pick schizophrenia, you would need to be given a time frame that fits it. And this guy, they didn't really give a major time frame for him per se. Okay. There's more questions down here. So these 3 questions are also pretty significant. First one, 29-year-old woman comes to the office due to depression. So now, as soon as you see the depression, you can already say it's not going to be bipolar 1 because there's no depression there. Right, so you can knock that answer choice out. Now you keep reading. Since breaking up with her boyfriend last month, she has been extremely sad and has difficulty getting out of bed. She describes sleeping 16 hours a day, increased appetite, 10-pound weight gain, low energy, decreased concentration, and loss of interest in social events. So that's pretty. She describes sleeping 16 hours a day, so she's not sleeping much at all, right? Actually, what am I saying? She describes sleeping 16 hours a day. She's sleeping way too much, right? 16. So she's literally just only awake 8 hours a day, right? But she's sleeping way too much. That's atypical, right? In depression patients, you don't see that. So that's pretty atypical. Increased appetite is also atypical, right? Normally, depressed patients do not eat. She's got a 10-pound weight gain because of all of that. And then the rest of this is normal, right? Low energy, decreased concentration, loss of interest in social events. The patient had several similar episodes in the past. When asked to describe the last time she felt well, she mentions a period of several weeks last year when she felt uncharacteristically confident, optimistic, successfully juggling 3 part-time jobs at the same time, felt well rested, energetic, and was only sleeping 3 to 4 hours. That's very hypomanic. Very, very hypomanic. That is exactly what a hypomanic patient does. That's what I described as, oh wow, being hypomanic is super awesome, right? Look at this patient, hypomania right here. Uncharacteristically confident, optimistic, 3 part-time jobs at a time, barely sleeping, has a lot of energy anyway. Perfect, right? So now you can see everything, right? You can see in this patient, she has hypomania, and she has this atypical depression of hypersomnia, hyperphagia. Bipolar 2 is the answer, and you just move on, right? BD2 patients have a history of non-overlapping BD2 and MDD, both things. Okay, very important to catch that the 2 things were happening at different times, not exactly the same exact time. Where do they happen at the same exact time? That's MDD with psychotic features. In MDD with psychotic features, you would have the major depression and the psychosis at the same exact time, never individually. Last one here, this is also good. 35-year-old woman comes to the office due to insomnia and fatigue over the past month. She has felt increasingly depressed, irritable, and hopeless since being let go from her job. The week prior to her last menstrual period was particularly difficult, and she stayed home. The patient has lost 8 pounds, feels unmotivated, unable to concentrate, looking for new work. She has hypothyroid and migraine headaches, so she takes levothyroxine and naproxen, which means that now you can just delete that sentence because whatever symptoms she has, whatever disease she has, she's managing it. Her TSH is 0.9, within the normal range, which means she's taking her medications. She drinks wine, often smokes marijuana once a month, she drinks wine often, which is okay. Smokes marijuana once a month, which is okay too. Physical exam is normal. What is her diagnosis? She's just depressed. You can see from the question very clearly she's not doing anything psychotic. Nothing psychotic at all. She's actually just doing things that fit the CGCAPs, right? Sleep disturbance, anhedonia, feeling of worthlessness, loss of energy, can't concentrate, lost weight, right? She doesn't have the P or the S though. No psychomotor retardation or suicidal ideation, at least yet. But in general, she's not doing anything psychotic. Right, so this is just MDD, 32%, while 46% chose a different answer choice of adjustment disorder with depressed mood. And it's totally understandable to see how someone could pick that. You have to be able to do the differential, right? Her 1 month of low mood, energy, loss of interest, insomnia, weight loss, and low focus suggest MDD. Adjustment disorder can only be the answer if symptoms do not meet criteria for MDD. As soon as your symptoms meet the criteria for MDD, you pick MDD. This is the more superior diagnosis than adjustment disorder, where you would have a couple issues, and we're gonna see adjustment disorder in a couple more pages. Yeah, right here. Right, emotional symptoms of anxiety and depression that occur within 3 months of an identifiable stressor, like losing your job or divorce or illness, lasting less than 6 months once the stressor has ended. If symptoms persist more than 6 months after the stressor ends, then now it's generalized anxiety disorder. But you have to make sure that symptoms do not meet criteria for MDD. When do symptoms meet the criteria for MDD? If you have 5 or more symptoms from the CGI-CAPS, and this patient had those 5 symptoms. She had depressed mood, irritability, hopelessness, lack of sleep, lack of appetite, anhedonia, lack of concentration. She had many symptoms that did match MDD. So you pick the more superior disorder, all right, the more superior diagnosis. Very important. We can stop right here because we actually covered a lot of very dense topics. Make sure that you create some kind of graph or some kind of outline for yourself on paper where you can actually describe the major differences between all of these. Right? You have bipolar, which is bipolar 1 if it's just manic, bipolar 2 if it's hypomanic and depression. And in bipolar, the two things occur separately, right? So separately. So you have hypomania and you have depression, and these things occur at different times, not at the same exact time every single time. All right, and cyclothymic is just a chronic version of it. And then we saw major depression. Here, in MDD with psychotic features, the psychotic features and the depression happen at the same exact time. Okay? Versus schizoaffective, where again the things happen at different times, but schizoaffective and bipolar are different from each other too. How? In bipolar, you don't really have psychosis per se. In bipolar, you have mood disorders, which involves mania or hypomania. Whereas schizoaffective, you're going to have schizophrenic things like hearing voices, seeing things, talking to yourself, not being clean, etc., etc. And schizoaffective is not just about depression; it's any mood disorder. So you can have the bipolar kind of thing, as well as hearing voices and seeing things. Okay, and all of that still is different from bipolar with psychotic features. This is not schizoaffective. Got to be able to make that difference too, right? And here we said it that to pick bipolar 1 with psychotic features because she has manic symptoms and delusions that occur only during the manic episode, whereas in schizoaffective, all of those psychotic things happen separately. The mood disorder happens separately, and it happens in the same patient, just never at the same time. Okay, very important to be able to see that timeline when you see a question. So oftentimes, what I would do is if I was reading such a question, right, I would actually create a very rough timeline. Like I would make a squiggly line for any time this patient was depressed, and a very straight line for any psychotic symptoms. And if I saw that the squiggly lines were overlapping, then I knew, right, that overlap means something. Whereas if the two things are occurring at completely different times, this is a whole different thing. So you got to be able to make those differentials. You got to come up with some kind of mechanism of how you're going to approach these questions. Otherwise, it's very easy to mess up and pick the wrong thing, as you could tell from the UWorld percentages of how many people chose the wrong answer choice. All right. So thank you very much for joining. That's all of your basic, really, really intense, high-yield schizophrenia spectrum disorders and depression, and all their differentials. Go ahead and study a little more. Make sure you get it down. In the next video, we'll go on to peripartum mood disturbances.